Okay, good afternoon. We're going to be talking about musculoskeletal problems. Hopefully this integrity will work. So the first thing that you have to understand are the differences between the anatomy or anatomical parts. We're going to first look at joints, which is also called articulations, and this is where two or more bones actually meet or come together. Joints are supported by different things. One of the things that we're going to look at is a ligament that usually attaches the joint capsule to the end of the bones. And then you have tendons that will actually join the muscles to the bone. So you have to understand the difference between a tendon and a bone. A tendon and a ligament. So when we look at strains versus sprains, a strain is usually a stretching or a tear in the muscle tendon or the muscle tendon unit. So this is an issue with the tendon itself or the muscle tendon as a unit. Whereas a sprain is usually a tear or a rupture to a joint or a ligament or the joint ligaments or the capsule that surrounds the joint. So sprains are more geared at ligaments. If you look at that, strains are more geared at the muscle tendon itself or the muscle tendon unit. So a strain, again, we're looking at a strain usually involves the muscle tendon unit. It's usually characterized by some pain and stiffness, swelling, and localized tenderness. Usually that pain is worse when we stretch the muscle in that area. We know that strains can occur in any age, but it's common in our middle age to older adults. Mostly due to aging factors, your muscles have less elasticity as you age, and so that's why a strain is more common in our middle to older adult. The most common sites of muscle strains that we'll see are like the lower back. Usually people aren't lifting properly. Also the cervical region of the neck, spine area. Those are some major areas of a strain. We do see some things occur in the elbow and shoulder, but the most common area is the lower back and the cervical region. When we look at a sprain, again, when we sprain an area, this is usually an excessive abnormal movement of a joint, specifically the ligaments. The joint ligaments is what we're stretching too much. The most common site for a sprain is the ankle, the knee, and the elbow. Usually, again, you'll see pain with rapid swelling and discoloration and limitation in the movement. Again, that's part of the vessels breaking, allowing more blood to enter the area, swelling and influx of fluid, things like that. And the limitation of movement is to kind of limit further injury. So we look at the pain with a sprain. The pain and the swelling usually lasts longer than a strain. Healing of tendons and ligaments may take anywhere from 6 to 8 weeks. So these are very slow to heal, both of these strains and sprains. The diagnosis for both of these, when we look at soft tissues, which is kind of what both these are, they're not bone, so they're considered soft tissues. We can't see those on an x-ray, so an x-ray really wouldn't do you any good for diagnosing a sprain or a strain. An MRI is the most sensitive test that we use to evaluate soft tissue injury. We look at terms like dislocation and subluxation. Dislocation is an abnormal displacement of the articulating surfaces of a joint. These are basically with the dislocation, those bone ends are not touching. Most often, dislocations are seen in the shoulder and acromioclavicular joint. When we saw a dislocation, again, remember that you have this surfaces of those two bone ends are not touching. They're not in contact with each other. A subluxation, so think of sub as partial. This is a partial dislocation, but there is still a connection or a touching of the bone ends. So we do see those kind of partially still touching. Manifestations of dislocation and subluxation, again, you're dealing with the joint and the bone ends. Here, there's pain and deformity and limited movement with both of these. And because we're looking specifically at the joint or the bone itself and not the soft tissues, in this case, a x-ray would be the most helpful in diagnosis. So when we look at fractures, we talk about this being a disruption or a break in the continuity of the structure of a bone. We use the term stress fracture to describe fractures or a break in that bone. That's really what we consider an incomplete break. So it's an incomplete fracture. It's usually due to excess stress, usually on a weight-bearing bone. So a stress fracture might be seen in the femur or the lower tibia fibula, weight-bearing bones, usually in unconditioned athletes. So a fracture occurs more with stress that is placed on the bone than that the bone is able to absorb, and so we see that occurring. There is another type of fracture which is called a pathologic fracture. This is used to describe incomplete fractures that occur spontaneously, again, not due to injury, but due to disease. So they occur spontaneously, usually due to disease, things like osteoporosis and Paget's disease. These are things that we're going to see causing pathologic fractures. This is where this is a fracture that occurs under normal stress to a bone that is just already weakened by disease. When you have bone fragments that have broken through the skin, this fracture is going to be referred to as an open or a compound fracture. So, for example, somebody falls, breaks their leg, their femur bone is sticking out of the skin. You can see the bone. That's an open or a compound fracture. When it's a closed type of fracture, closed is going to be dealing with no communication with the outside environment. So we definitely have a break or a fracture in the bone, but it's all within the skin. There's nothing poking out. So that's a closed type of fracture. With which type of partial fracture is typical in children and resembles when a young sapling is broken? This is called a green stick fracture. It's a partial incomplete break that we typically see in children. Now, a sapling is like a very young branch of a tree that is still alive, and it's very bendable, and that is why we see that in children, because their bones are a little bit more pliable, and so that's what it's called. And I think I have a picture for you here in just a bit. The characteristics of fracture pieces. Let's see. Right. So, okay, I'm sorry. So the degree, when we're looking at the degree of fracture, we're using words like, open and closed, those kind of things, complete or incomplete. That's how we're looking at what degree of fracture we're dealing with. The character of the fracture pieces may also be used to describe a fracture. And when we look at things like a fracture, we're going to skip a slide, with more than two pieces, that's called a comminuted fracture. It has more than two pieces. Again, comminuted, that's just a characteristic. When we look at compression fractures, on the other hand, this is usually in the vertebra column, involves two bones that are usually crushed or squeezed together. So compression fracture kind of might be seen like with an elderly person, um, or in some cases when something heavy falls on somebody, somebody jumps on somebody, or they fall down. You might see compression fractures in the vertebra that compress each other. It usually involves two bones that are crushed or squeezed together again. A fracture is called an impacted fracture when the fracture fragments are actually wedged together. They're impacted. A lot of times we'll see that with the femur bone. When a fractured bone is restored to its normal anatomical position, we call this reduction. And so what we'll see is that, for example, if somebody comes in and they've broken a bone, and the doctor's kind of like, you'll see them in the movies and they're like 1, 2, 3, and they pop them back into place. This is called a closed reduction. They didn't do anything to open the patient up. But if they have to go into surgery and make an incision to put the bone back together, then that's called an open reduction. But a reduction is when we restore the normal anatomic position. Now, a fracture that results from a twisting motion or a torque type of motion is called a spiral fracture. This is very common in like abuse kind of situations. The parents, turning the arms, those kind of things. So going to this picture here, what you see in the middle, this middle picture here would be an example of that green stick fracture. Remember I said it's like a bending of a sapling in a young child. This bone here of a young child is more pliable and can bend a little bit and give. So that you don't quite have a break all the way through, but you can see this fracture has occurred. This is a closed type of fracture because there is no breakage of the skin. There's no clear observation of bone. Whereas this would be an open or a compound type fracture, which would be obviously terrible. There's lots of things that will be more at risk with this patient. So you want to be able to identify the pictures if you can. Signs and symptoms of these fractures, of course, you're going to have cardinal things like pain. It's going to be swollen. You're going to have a break in the vessels, so the tissues are going to leak blood and fluid. There's going to be an abnormal mobility. Most of the time, there's loss of function and mobility in that area. When the nerve function at the fracture site is temporary, when we have temporary loss of nerve function at the fracture site, and the area becomes numb and tingly, we call that local shock. So you broke your arm, and in that area, there's some major nerve function that's lost temporarily. Again, that's called local shock. Now, muscle spasms and contractions, that's something else that we will see. And it's very painful when your bone is spasming and you have this fracture going on. So again, pain, tenderness at the site, swelling, loss of function, deformity in that area, abnormal mobility. Those are all things your book discusses as some of the manifestations. Again, don't forget the local shock when we temporarily lose the nerve function. And again, this is a bone issue, so an x-ray is going to be a really helpful diagnostic test initially. Now, when we look at complications that result from skeletal trauma and soft tissue trauma, what we see is muscle injury and swelling. And the thing that we're going to be looking at is compartment syndrome. When we look at adipose tissue and bone marrow complications, generally what we're going to be looking at is fat emboli syndrome. So let's kind of break these down and talk a little bit about them. Compartment syndrome is a condition where there's an increased amount of pressure in a limited space, which ultimately compromises the blood flow, decreases the blood flow and the function of the tissue. A big cause of compartment syndrome is bleeding and swelling caused by a fracture and or possibly bone surgery. When you decrease the compartment size, decreasing the compartment size or increasing the volume Both of these things are causes of compartment syndrome. So bleeding into the tissues, swelling and edema, those things will cause compartment syndrome. So if you think of something that, like a cast on somebody's arm, if there's swelling that is occurring underneath the cast doesn't expand and doesn't give. So we've decreased the size of the compartment and have like a constrictive bandage, dressing, something like that. That is something that we can see, or that people are at risk for compartment syndrome if they have like a cast or something like that. Circumferential burns, that's another thing that we worry about. I think we already talked about that in the fact that a circumferential means a burn that's all the way around, and as it swells, it acts like a tourniquet in that area. And so it cuts off the blood supply. So too much volume in that area, or a decrease in the compartment size, or both. These are big things that we look at in association with compartment syndrome. What we talk about as a hallmark symptom of compartment syndrome is pain that is so severe that it's out of proportion to the initial injury. So the person has obviously, has something going on, but they're complaining of pain so bad that it doesn't match the type of injury they have. Oftentimes they'll have numbness and tingling also. There can be necrosis of the muscles that occurs within about 4 hours, and so it's important to recognize and treat this in a timely manner. Now, we look at something called fat emboli syndrome as a complication. What I want you to really get from this is, and your book does talk about different types of fat emboli, but what I want you to understand is that it's very common that when we break a bone or we fracture a bone, there is a disruption of the venous synoid and the fat cells that allow fat globulins to be released in the circulation. And so this large emboli blocks the capillaries, and small ones just get through to the circulation. So eventually they can lodge into the pulmonary system, causing pulmonary embolus, which will cause respiratory failure. You may have them into the cerebral circulation, causing strokes or dysfunction there. Another thing that we might see with fat emboli is the skin and mucosal petechiae. So these little tiny clots being, thrown and dispersed throughout the body. The important thing is to understand that with any kind of skeletal trauma, or even orthopedic surgeries, knee surgeries, hip surgeries, anything like that, there's a risk of these fat embolus, and something that we need to pay attention to in a patient. Okay. So let's go backwards a second and talk about bone healing. And we have to understand the normal process of bone healing in order to understand impaired bone healing. And again, I give you some page numbers to go back into your textbook and read a little bit on, but you need to, in general, have an understanding of what is going on. There are different phases that we go through when we try to heal a bone, and the first phase is the hematoma formation. When a bone breaks, the vessels in that area and the surrounding tissues, they become torn and they leak blood and fragments into that area, and what happens is it forms a blood clot, which we call a hematoma. But there's a purpose for that hematoma, and the purpose for that hematoma is to basically seal off that area and protect it, while it allows the inflammatory mediators to kind of come in and do their job. So hematoma formation facilitates that formation of clots and fibrin meshwork that kind of seals it off. It kind of serves as a mediator for the inflammatory cells to come in and kind of clean up and fix the problem, which moves us into phase 2, which is called the fibrocartilaginous callus formation. Now, this is important to understand. So you have the capillaries that infiltrate the hematoma, and they form a new granulation tissue, and this is called a procallus. So the granulation tissue forms, and we have these fibroblasts that grow, they invade that hematoma, and they produce this soft callus bridge. So you have this new bone that's starting to form, but it's very soft and pliable. It's a fibrous, it's a cartilaginous type of substance. It connects those fragments together, the broken fragments. However, it's definitely not strong enough to bear weight yet. And usually this granulation and fibrocartilaginous soft callus bridge, this phase is usually complete around 3 weeks. So after about 3 weeks, we have this new little, growth that's occurring that's very soft and pliable and is easily to damage. So of course we can't, bear weight with that extremity yet. In phase 3, we form a hard bony callus. This is called ossification. This is where your calcium salts have deposited into the new tissue, and it forms the formation of bone, actual hard bone, progresses until that fracture site has a true callus or bony callus. So this is where the bone becomes more hard, and you have the osteoblasts that are deposited on the outer surface, and they help make this a hard bony callus. Let's see, invasion. Oh, sorry. This ossification process doesn't begin to start until around 3 to 4 weeks after the injury. So they have to develop this granulation tissue. They have to in phase 2, and they have to have this procallus formation in order for this ossification and next step to occur. So you have to kind of understand that. And again, that chart on those pages kind of will really help you. Now, in the last phase, we call this the remodeling phase. This is where the dead portions are removed by osteoclasts, and there's a reorganization that occurs in that area. The healed bone usually resembles the original bone. And so that's kind of the process of what happens in a normal bone healing process. So what are some things that cause our body to not heal properly? The book goes through quite a few things. I'm going to talk about 3 major ones. Poor nutrition, diabetes mellitus, and circulatory issues. These are 3 of the major causes of impaired bone healing. Usually patients aren't or nutritionally deficit in some things, whether it's vitamin D, whether it's vitamin C, just protein and things in general. So poor nutrition, they're not eating properly. Diabetes, the sugar's too high, it increases the risk of infection and bacteria. Circulation to that bone is impaired possibly. Other things that we'll see are like age. Usually the older we are, the less we heal. Medications that people are on, those are some things that you might see also causing impaired bone healing. If they have any kind of circulatory problem or coagulation, clotting problems, those are some things that we would see. But your biggest things that are causing the bone not to heal is going to be poor nutrition, diabetes, and circulatory issues. Now, you can have some different problems and complications when the bone is not healing. So we're going to look at some terms. One of the first terms that I want you to understand is called a malunion, M-A-L union. It's not only, oh yeah, it is. It's a bone that heals with a deformity. So it either has a deformity, some type of angulation, or an abnormal rotation when it heals. Usually you can see that on x-ray, and so that is called a malunion, a bad union, okay? It healed improperly. Now, we look at another one called a non-union. It didn't make a union. So the bone is not healing properly. Yet what we see is that pain is still associated with weight bearing. So the patient in this case will try to be pick up, let's say they broke their arm, for instance, and they're trying to lift a gallon of milk. They're having severe pain just lifting the milk. There's a lot of pain associated with the non-union fracture. There's a lot of movement at the fracture site, And generally we classify it as non-union fracture after they've had this fracture for 6 months and it's not connected. Okay, it's not made a union. So 6 months is kind of like our time frame. We will use the term delayed union if there's a failure of it to heal within the first 20 weeks, because the majority of fractures in bone should heal within 20 weeks. When that does not occur, we say it's delayed. But if it goes on more than 6 months, then we consider a non-union fracture. So let's look at one of the types of infection of the bone, and this is called osteomyelitis. This is an infection of the bone or the bone marrow cavity. Usually it can be caused by a direct contamination, so like an open wound or an open fracture, the bone's poking out, or maybe they had orthopedic surgery, or they have these, we call these pins. They have infected pin sites when they're in like traction or skeletal traction. Joint replacement surgeries. They have these foreign objects that are put into their body. So these are ways that they can get like a direct contamination of the bone. When we look at hematogenous contamination, this is going to be an introduction of bacteria or organism through the bloodstream. And this is predominantly seen in children. We do see hematogenous contamination in adults, but mostly in adults that are debilitated already or adults that have chronic skin and urinary tract infections. Let's see. The way that it affects kids differently than adults is that in children, the infection usually affects the long bones of the appendicular skeleton, so like the femur, the tibia, fibula, the humerus, the radial ulna bones, those long bones of the appendicular skeleton. But in adults, it affects the vertebra, the sternoclavicular bone, the sacroiliac joint, and the symphysis pubis. So those are some differences in how hematogenous spread occurs. Now, with osteomyelitis, bacteria is generally the most common cause, and we do see Staph aureus as one of the most common bacterial causes. So those things are important to note as well. If this osteomyelitis is not caught, fairly soon, the bone will start to necrose and die. Some of the manifestations that we associate with osteomyelitis, again, this is an infection of the bone, and so what we'll see is a persistent or recurrent fever that happens or keeps coming back. Oftentimes, these patients with the fever, they will have chills. Pain gets worse and worse and worse. And anytime you have an infection, there's going to be poor incisional healing. So these are just a few of the manifestations that you would see with osteomyelitis. Now, your book goes into chronic and acute osteomyelitis. I don't really go into all of that. We talk mostly about the acute type. But again, chills and fever. Often there's pain on movement in the affected extremity, loss of movement. Let's see. And that actually is going to conclude this first portion of musculoskeletal.